Hi, my name is Erin Willard. I am an emergency medicine physician. I recently graduated from residency from the University of Arkansas for Medical Sciences in Little Rock. I was part of a team that looked at empathy in the physician and patient interaction in the emergency department. And specifically, we looked at the correlation between resident physicians and patient perceptions of empathy in the ED. To give a little bit of background on the subject, empathy is the ability to share and understand the feelings of another person, and it's one of the major factors associated with a positive patient experience in the emergency department. There has been research into the perceptions of physician empathy and patient experience, both from patient-reported or patient perceptions of physician empathy and physician self-reported empathy. But there is little data that exists about the empathy for resident physicians, specifically not emergency medicine residents. This is a systematic review from 2018 from the Journal of Patient Experience, and it shows, or it just sought to identify which factors were most influential in the patient experience, and staff empathy and compassion was very important, just behind staff-patient communication and ED wait times. The objectives of this study was to look at both patient and resident perceptions of resident physician empathy during the encounter, and we did that using the CARE tool, which I'll get into in a little bit. And then we wanted to see if there was a correlation between those perceptions. CARE stands for Consultation and Relational Empathy, and it was a tool that was developed as a way for providers to get direct feedback from their patients on their communication and their ability to be empathetic during the encounters. This is a systematic review from 2017, and it showed that this CARE tool was used in 64 different studies as a way for patients to evaluate their providers. And so it is a validated tool. This survey is 10 questions, and patients can rate their providers from 1 to 5, 1 being poor, 5 being excellent. And it asks about all the things that you would expect from an empathetic provider. Somebody who makes you feel at ease, listens to you, understands your concerns, is positive, explains things clearly, and can help you make a plan of action. So the best score that you could get on this as a provider would be 50. We not only administered this tool to the patients, but we also administered the same tool as to the residents. So we changed the wording a little bit so that they could evaluate themselves. So it's how good were you at making a patient feel at ease? How compassionate were you? How well did you perform at making a plan of action with your patients? And so that they could evaluate themselves as well. The methods of this study: this was a prospective observational study in an urban academic emergency department. We obtained a waiver of consent by our IRB, and this tool was administered via iPads on REDCap to 2 different populations. First, the ED patient was approached to participate in the study, and if they agreed and filled out a survey, then the research assistant would identify which emergency medicine resident was caring for that patient, and then they would also approach them to participate in the study as well. It is important to mention that the residents were blinded to the results from the patients, so they do not know how they did during that encounter with their patient. In addition to the survey data, we collected basic demographic data about the patient population and the gender and the training year for the resident physicians. Our average patient age was 50 years old. The majority of patients were female and were African American, and the majority of the patients were discharged home. In addition to whether or not a patient is admitted or discharged, they can also go to the clinical decision unit, which is a short observational unit, kind of serves as an extension from the emergency department. So that's just what that means. This chart on the right shows the breakdown of the surveys collected. So in total, we have 185 surveys in which a patient was matched to a resident physician. There were surveys completed by both populations. We did attempt an intervention in early March in which we were going to show the residents their results. But because of the coronavirus, we had to stop that early. So all the results that you're seeing are from 149 matched surveys from before that intervention. So just kind of keep that in mind. The data is going to be displayed in both scatter plots and box plots. The scatter plot here is cumulative of the data, and it shows that the scores by the patients from 10 to 50, again, 50 being the best, on the y-axis, and then the scores that the residents gave themselves on the x-axis. The line running through the middle of the chart is the line of agreement, in which a patient and a resident would give themselves the same score. Anything above that line shows a score that the patient gave that was higher than what the resident gave themselves for that encounter. And then a score below the line is when a resident gave themselves a score that was higher than what the patient gave them. So as you can see, the vast majority of surveys collected show that patients rate residents higher than what they are rating themselves. This is that same data just shown in a box plot. Again, the scores are on the y-axis, and it shows that patients rate residents significantly higher than what they rate themselves. The median score given by the patient was 48 out of 50, and the median score that the residents gave themselves was 35 out of 50. Still very good, but much more conservative, and it is a significant difference in what their patients rated them. We looked at this data several different ways. So first, we're looking at the training year of the residents. So to give a little bit of background on our program, we are a 3-year emergency medicine residency. We have 10 people in each class, so a total of 30 residents, and 11 of those are female and 19 of those are male. Just kind of important information as we're going to explore gender later. The patients did not see a significant difference among the residents between the 3 different classes. As you can see, the residents in the 2nd year class rated themselves lower than their co-residents in the intern class and in the 3rd year class. There was not a significant difference between the 1st and the 2nd year, but there was a significant difference between the 2nd year and the 3rd year. So this could be just the class itself, because we only collected this data last year, but it also could be that in the 2nd year we're expected to pick up a lot more patients, and we are expected to run our side of the emergency department. So things become a lot more stressful. We see a dip in confidence during that year. It could be part of the explanation, just one of the factors of going into what we're seeing here. We also wanted to look at how the scores changed over time, between November when we started collecting data and March when it was concluded. And over time, patients didn't seem to see a difference. But then residents, you can see maybe a slight downward trend in self-reported empathy. But what I think this graph is more helpful in realizing is the importance of who's collecting your data. So we use research assistants from a neighboring university who were students. So that big gap in data collection is from their holiday break. So pretty significant break, but it just show one of the limitations of this study. Next, we broke down the patient scores and the resident scores by patient age. So you can see that older patients tend to rate our residents a little bit lower, and our residents rated themselves a little bit lower in the 40 to 60 age group, but not a whole lot of difference here. We also looked at scores by the patient race. So again, majority of our patients were African American, and the other category includes American Indian, Alaskan Native, Asian, Native Hawaiian, other Pacific Islander, or those individuals who listed 2 or more races. Again, they're pretty similar in both how patients felt that the residents did, and then how residents felt that they did among different races. The disposition of the patient may have made a little bit of an impact as well. So the vast majority of these patients were discharged, but you can see that patients tended to rate residents very similarly, whether they were admitted or discharged or sent to the CDU. And then residents maybe rated themselves a little bit more highly whenever they admitted patients to the CDU or were discharged. And that could reflect a little bit of the shared decision making and those conversations that happen whenever we send a patient home or when we send them in for observation. And then I think that this is when our data gets really interesting, and when we're looking at both when we're looking at gender. So male patients tended to rate our residents a little bit lower, and then our residents felt that they performed a little bit worse when they had a male patient. So then that asks, well, what about the resident gender? So the female residents, as you can see, patients felt that female residents were pretty similar to males, maybe a little bit lower. And then the female residents rated themselves significantly lower than their male counterparts. And so then we wanted to ask, well, what does it look like when you factor in the patient and the resident gender interaction, and see what does that look like? So the vast majority of the encounters in our study were between a male resident and a female patient. That's about 40%. And then the fewest encounters were between a female resident and a male patient, only about 13%. So this chart shows the gender interaction between the patient and the resident. So the first gender listed on the x-axis is that of the patient. So the one with the capital letter is the patient's gender, and then there's a period, and then there's the resident gender, the one with the lowercase letter. So looking at the patient scores, when a male patient had a female resident, they rated them a little bit lower than all of the other gender interactions. But when you look at the resident self-reported empathy, male resident physicians felt that they did well between both genders, and it was pretty similar between both genders. But when you look at female residents, not only do they rate themselves lower overall between both genders, they felt like they did significantly different whenever they had a male patient. And I think that this is very interesting. So looking at the results overall, there is a significant discordance between what the residents feel, or how the residents feel that they did, and how the patients feel that the residents did. The residents rated themselves significantly lower overall. Second-year residents tended to rate themselves lower, and male patients rate female residents lower than they rate other male residents, or than they rate the male residents. And then female residents rated themselves significantly lower overall than the male residents did. So there's some limitations to this study. As I mentioned, that there's a gap in the RA availability from December to January due to their student vacation, so we weren't able to collect surveys at that time. Resident participation was somewhat limited because the emergency department is a very busy place and they're extremely busy, so it's kind of hard to catch them at a moment where they can fill out a survey like this. But overall, I think we did get a good number of surveys. This is not a controlled environment by any means. So in the emergency department, a patient is going to meet many people and interact with many individuals, so it's kind of hard to isolate their experience with that one resident. To try and control for this, we did show the patients photos of the residents that took care of them and gave them names and everything to try to jog their memory. But obviously that's something that would skew the results. And then coronavirus. Unfortunately, we're not able to complete our intervention as planned. So in conclusion, overall patient perceptions of resident empathy are very high. They think that we're doing a great job. But there was significant discordance between how the resident felt that they performed and what the patient thought. And it seems like the most influential factor affecting perceived empathy was resident gender. Female residents rated themselves much lower. And then this poor correlation, I think that this is a great opportunity for further study. We can see, what behaviors or what communication exhibited is a sign of a good or a very empathetic provider. What things should we be looking at specifically? And then between gender, why is it that female physicians in the emergency department are perceived as being less empathetic than males? That's kind of counterintuitive. And then, what role does job satisfaction or wellness and training have to do with this? Would we see these same trends in attending physicians or community practice physicians who have been doing this for longer? So I think there's a lot of good questions that could come out of this study. Thank you so much for listening. Again, my name is Erin Willard, You can forward any questions that you have to me at this email address. And thank you so much. I hope you take care of yourselves and stay healthy.